Okay, thank you, Anne, and thanks very much to the organizers of this event for having me. It's been a really interesting series of discussions and presentations so far, and I'm really glad to have the opportunity to share with you some of the work we're doing at the U.S. Agency for International Development in global health, urban health, and using artificial intelligence. So what I'm going to do is pick up on some of the themes that have just come up over the past couple of presentations and put them in the global health context. And to set the scene, what I'll do is talk a little bit about some of the statistics that put into sharp relief the opportunity and the challenge around urban health in low and middle income countries. So by 2030, 60% of the world's population will live in urban areas, and that's up from 30% in 1950. USAID was started in 1961. So you can imagine how the future of our programming needs to look much different than our programming has historically. Africa and Asia, currently home to 90% of the world's rural population, are the fastest urbanizing regions. We're going to be at 54% of the regional population in urban areas in Africa by 2050, and 64% of the Asian population living in urban areas by 2050. And so what does this mean when we think about the future of USAID programming? There is the physical proximity that urbanization forces and facilitates that really makes us take a step back and think about how the future of cities and the future of global health is really about the confluence of what historically we have treated as different development sectors. Food security, population health, environmental health, climate change. These are all things we need to be thinking about as components that influence each other and things we need to be addressing systemically and holistically if we are going to achieve healthy cities of the future. So to put this a little bit more into fine points, extreme poverty by 2040, cities will account for the majority of people who live on less than $1 a day. These urban poor are spending a much larger percentage of their household budgets on food, making them more vulnerable to food shocks. From a health perspective, nearly 50% of city dwellers in Africa, Asia, and Latin America suffer from at least one disease caused by lack of safe water and lack of sanitation. So these infrastructure issues and how infrastructure affects population health in cities. From a climate change perspective and an environmental security perspective, a couple of factors here. One is that cities themselves are major contributors of greenhouse gases. 70% come from cities, and cities also consume 2/3 of the world's energy. Cities are also, in large cities in particular, are also more prone to damage and shock from natural events. 80% of big cities are vulnerable to earthquakes, and 60% are at risk from storm surges and tsunamis. So the USAID urban team has been thinking about the confluence of all these factors and thinking about how sustainable urbanization is central to meeting many of the global development commitments that we talk about as a development community across sectors. This includes the 2030 SDG agenda, the Paris Agreement on climate action, the Addis Action Agenda on financing for development, and the new urban agenda. And again, what we're going to be looking at across USAID increasingly are partnerships, access to financing, local capacity building, including at the local municipal government level, which is something that I think we've heard quite a bit about in some of these earlier presentations, to be able to effectively think about how these different components interact with one another, but also as we have rising access to digital technologies, increasing amounts of data produced by these digital technologies, how we as development actors are effectively leveraging that data and supporting the digital systems that enable that data, but also building the capacity. This is really critical, and it's come up in earlier presentations, that human and institutional capacity to use the data is critical. And I think we as a sector have underestimated the amount of work that the process of digitization entails to help people go from using paper data, which comes at less regularity, less frequency, to digitized data, which is coming in a near real-time environment in some cases, and is not only just more data, it's often a different kind of data. And if you want to move actors, including municipal governments, to an environment in which they can make real-time decisions based on real-time data. That is a completely different set of processes and skills amongst the workforce, institutional policies and processes that are required. And I think that's an area where we still have a lot to learn and a lot of capacity building to do. So let's switch gears a little bit and talk within the context of digital technologies about artificial intelligence. So I sit with a team in the USA Global Health Bureau called the Center for Innovation and Impact, or CII. We partnered with the Gates Foundation and the Rockefeller Foundation and the Boston Consulting Group to produce a report that we launched a couple months ago called Artificial Intelligence in Global Health, Defining a Collective Path Forward. I've put the URL there, usaid.gov/CII, for anyone interested in downloading the report. And what we did was look at what the opportunities are, the big goals we have in the global health sector, and what some of the constraints we know we face in low and middle income country environments in harnessing the potential of digital technology and artificial intelligence. So we know we have these very ambitious goals of increasing the access and quality and equity of healthcare in these environments, increasing efficiency while reducing costs. So these are not easy things to do. And we know we also have constraints we need to bear in mind. Digital technologies are very rapidly increasing in reach, but they're not yet everywhere. And where we have digital divides, we also have data divides. And that's relevant in the context of artificial intelligence because artificial intelligence requires large data training sets. And so we were joking earlier about these aerial photos of Chinese warships attacking Taiwan. And if you had 10,000 of those photos, then you could train the AI. And it's a similar kind of challenge here where if you don't have a lot of digitized data about what the local population needs are, it becomes difficult to have sufficient data to train the AI. And if you try to use data from other sources, you're likely going to introduce bias. And so that's something that we need to be very mindful about. Unsurprisingly, in low and middle income countries, we also have nascent policy and regulatory environments around these technologies. This is a challenge globally, not just in LMICs, but particularly there. We see the technology moving oftentimes very quickly ahead of the policy and regulatory environment. So what we did with this report were a few things. First, we did a landscape of existing artificial intelligence building blocks. We took a very broad definition for AI, including machine learning and other of the technologies commonly grouped under that umbrella. And we identified which were the most relevant in the global health context. We then also looked at potential global health sector use cases, identifying 27 different use cases, of which we took 4 as priority areas where we might want to move forward with partners and exploring areas of investments, partnering with countries to understand what their needs and hopes and opportunities were in order to begin taking that forward. We also landscaped existing AI solutions for those in the room interested in specific AI tech companies. We cataloged over 240 current examples of health-focused AI solutions. So this is the landscape of the building blocks. We took 6 here: computer vision, speech recognition, natural language processing, information processing, machine learning, and speech generation, and highlighted those as most relevant. And then we looked at the particular use cases where those most relevant AI building blocks might be applied. And we mapped 27 areas looking at population health, individual health, care enablement, and pharma and medtech. And from there, we got to 4 priority global health use cases. The first is around AI-enabled population health. So here we're talking about, for those who do have access to mobile phones, digital tools, how can we be supporting individuals' ability to best promote their own wellness, and where they do have care issues, to support their ability to identify what those are and to seek available support. For patient virtual health assistants, also taking steps like being able to come up with specific, in the case of the United States, we talk about pre-diagnoses, so where you can have a symptom checker to try to understand what's happening, and tied together with suggested behavior change, and in some cases referral for care. Frontline health worker, virtual health assistant. This is really important in the context of low and middle income countries. We have very dedicated community health workers, frontline health workers, many of whom who work without regular pay and have minimal training and very important jobs, because a lot of people rely very heavily on these individuals for the vast majority of their care. And so this is a really critical opportunity to be empowering those frontline and community health workers with decision support tools that enable them to best be able to provide care to those who are seeking it. And then finally, physician clinical decision support. This is providing more specialized expertise to generalist physicians. So for example, enabling a GP to read diagnostic images there on the spot. So what are some of the common challenges to scaling artificial intelligence in low and middle income country settings? There are a few, and I want to point out that these are challenges that are not unique to artificial intelligence. They're challenges that reflect our experience leveraging digital technologies overall in low and middle income countries. So Anne and Jeffrey and I, a couple weeks back, were in Geneva for the International Telecommunication Union's AI for Global Good Summit, and a number of the people who were participating in those discussions who have been active in the digital health space for the past 10 years were commenting, there's something about this new generation of technology that is embodied by artificial intelligence that is reminding people a lot of the hype and excitement when mobile phones began to very rapidly proliferate in sub-Saharan Africa and elsewhere in the developing world. And so I think we've learned a lot from that experience, that mHealth experience, and those lessons we need to be bearing in mind when we think now about the application of AI in global health. So data quality and availability, I've talked already a bit about privacy, ethics, and ownership. I've actually probably talked a lot about it, but not here today. Integration into health systems. This one is really critical, and this is an example of a lesson learned from the wider field of digital health, where when you have people who are building digital health applications that are siloed from government systems, it creates a lot of challenges, in particular for public health decision makers who find themselves in a country where you may have 150 plus large-scaled digital systems with public health data in them that are not interoperable and not connected to public health systems, which means that you, as a public health decision maker, don't have immediate access or holistic picture of access to what your public health needs are, which you can imagine might impede your ability to make effective decisions. So that's an important lesson that we need to be bearing in mind. The privacy, ethics, and ownership component, there's a lot here. There's definitely a health equity challenge. So if you are not somebody who has access to a smartphone or 4G connectivity, will you benefit fully from the AI revolution, as some people are calling it? There are also ethical issues around patients who may receive diagnoses that should be communicated with some kind of counseling support and may not be via a smartphone. There are also concerns about companies inappropriately profiting from or monopolizing what could potentially be more appropriately considered public health data. And then we've seen recently an article from the chief scientist at the World Health Organization talking about should public health data be a public good, and what does that mean for some of these data-intensive AI programs. Integration into health systems. We've talked a little bit already about the health system capacity and the change management that's required to enable these health systems to function effectively with digital tools, and the need to avoid further fragmentation. And with the end of the report, what we did was we looked at the range of actions that are needed to identify a collective path forward. These range from technical assistance to innovators to help them navigate complex, sometimes contradictory regulatory environments, helping them with business model sustainability, but also importantly the broader ecosystem support. And so how can we be working with our partner country government officials on the policy and regulatory front? What do we need to be doing to be thinking about interoperability of systems, and how importantly can we be building the capacity of partner governments? So I'll leave it there, but I think overall there's a lot of optimism and hope for this space, but also some significant challenges ahead, and I look forward to the discussion. Thank you.